Good morning to you all. First of all, I would like to thank the organizing committee for making it possible to meet with you. I will look at it from the epidemiologist's point of view. I will try to contribute to about correct reading and correct interpretation of the results. I want to start with the slide. The message that we want to convey here is, based on the sample, we try to foreshadow things about the universe. And through this estimation, we try to get the result which is close to the reality. Rothman is one of the most important opinion leaders in epidemiology. If your sample size is not enough, then based on chance or random error might face us, and we might not be able to do a correct foreshadowing into the universe. But you have a chance to find results which are close to reality. But bias, systematic error, if there is a systematic error, if there is a bias, no matter how large your sample size is, at the point of analysis, at the point of interpretation, it's impossible for you to detect the truth. Therefore, what we try to do in the study is try to find the answer which is the closest to the reality without the effect of bias. You might do a perfect work, but if there is a problem with the design, if there is a problem with the continuation, then you cannot do anything about it. But there is a problem with the sample size. All you have to do is increase the sample size. What do we mean by being away from bias? Internal validity. We are talking about internal validity of the study. What is internal validity? We have an outcome that we are interested in the study, and there are independent variables that are related to this outcome. In this study, we have to find the relationship between the outcome variable and the other variables, and if we can really determine the relationship between these elements clearly, then we say that the study has an internal validity. This is what we mean by internal validity. It's possible to ensure this. What do we do? To prevent any problems, we exclude some cases from the study. This might be a disease, it might be a certain age group, it might be comorbidities, anything that might have an influence on the internal validity. These subjects you exclude from the study, or both the samples cases we include in the study, we try to make it as close to the universe, the population, as possible. Therefore, we do random sampling. We do matching in order to prevent the effect of other variables. That is, we try not to relate our variable that we're interested in and the outcome variable without being influenced by the other variables that might cloud the results. What do we do if we cannot do this? We do multiple analysis. We do regression analysis. Try to get rid of the other factors, leaving the factor that we're interested in. We do masking, double blind. Sometimes a statistician analyzing the results might be blinded as well, triple blinded, and effect modifier. And we do stratification. By stratification, we try to determine the effect of the variable then we get a high internal validity. But there is a difficulty. You might do all of these things, but then you might disturb the external validity of the study. What did we do? You excluded certain cases, or you tried to match groups, tried to make groups as similar to each other as possible, but then by doing this, you might endanger the external validity of the patient. That is, the results of the study might not be able to be generalized. Statistically speaking, P less than 0.05, if it has no clinical relevance, then it has no contribution. Statistically speaking, significant difference, if it supports clinical observation, then it is important. But if it has no clinical observation, P on its own has no importance. Field research always has higher external validity because the ratio of the general population to be represented is higher. But at the experimental setting has a difficulty with the external validity. For example, you perform randomized controlled studies. They are at the highest level of the evidence pyramid, but with randomized controlled studies, there's a disadvantage. It's very difficult for these studies to be generalized. That is, their external validity is discussed very severely, because you in your daily life, in your daily practice, you do not see these patients which are included in these randomized controlled studies, because these are very highly controlled patients with certain characteristics excluded from the study. Therefore, it's very difficult for the randomized studies to be applied into daily practice. What is the result? For us to make meaning out of studies, internal validity is crucial. However, if you cannot reflect this onto your daily practice, no matter how perfect the study conducted is, if there are limitations in the cases, in the sample, then your external validity will be very difficult and you will not be able to generalize the results. I want to talk about the p-value. What is the p-value? I will talk about this in detail. It's alpha mistake, alpha error. Error caused by the researcher. That is, in reality, there are no differences between the two groups that you are analyzing, or in terms of drugs, you find the difference between the two drugs, which actually in reality is not present. This is called the alpha error. Why do we try to get P less than 0.05? This means I found A drug to be superior to B, and the possibility of mistake is less than 5% is the message we are trying to convey. Mistakes, errors less than 0.05 are considered to be random, luck, chance errors. These are acceptable errors. But there is another type of error, which is called beta error. That is, although there is a difference between the two groups we are comparing, you might not be able to find this difference. In terms of drugs, A is superior to B in reality, however, you are not able to find this difference. What is the problem here? The main problem usually is the lack of sample size, the inadequacy of sample size. And you usually get this result from the referee if you're sending this to a publication. You have not found this error, but is it because of your low sample size, or is it because there really is no difference? Therefore, you have to make a power analysis and determine your sample size. And they ask you if you have performed this power analysis and determined your sample sizes accordingly. What is power? It is 1 minus beta. Alpha error, the threshold is less than 0.05. This changes, of course. It can be 0.10, very rarely, but with very important issues, alpha error can be taken as 0.01 as well. For beta error, errors up to 0.20 is accepted, because if you go beyond 0.8, then your sample sizes get too large to be realistic. What is the safety range? It gives us more information. Reliability range. Reliability range is the average range, safety range. If you have a continuous measurement, your standard deviation, the variance, and sample size get into the picture. Therefore, it is affected by the sample size. Let's look at the odds ratio. There are three values. Güvenilir reliability meaning, güvenilir reliability range.
Confidence interval.
Confidence interval. You see is there a difference between depressed patients and non-depressed patients in terms of family history? The result is positive family history is above more than 1.73-fold, 1.11-fold, and more than 3.91-fold. The study where the family history to be affected, the lowest was found in the second study, but confidence interval was between 1.03 and 1.72. If I make this study 100 times of the 95, I will find results between 1.03 and 1.72. There is a value of 1. What does it mean? In one of the studies, I will find odds ratio to be 1, which is there is no difference between the two groups. When you see this 1, you can say this, yes, this might be 1.73, but this is not statistically significant. The p-value, it should be above 0.05. This is 391. Again, the range is 0.6, 14.7. Of the 95 studies, one study at least will yield us 1. Therefore, this is not statistically relevant. Relative risk, the lowest relative risk was found with the second study. If we look at the confidence interval, there is no 1 in it, therefore this is statistically significant. According to P, why is confidence interval superior? You see that the confidence interval is narrow and large in different studies. This gives us an idea about the sample size. We say that the first and the third studies are inadequate in terms of sample size, but the second study must have had an adequate sample size because the confidence interval range is narrow. Had the sample size in study 1 and study 3 been larger, perhaps they would have found the same thing. Again, if the confidence interval involves 1, then in terms of odds ratio, it's not statistically significant. Let's see that confidence interval and p-values change by the sample size increase. Let's see, 120 people, half of them exposed to the factor, half of them not exposed. You see 8.3%, p-value 0.13, and it's not less than 0.05. Yes, relative risk is 1.8. How did we find the relative risk? It's 9.60, 5 over 60, 9 over 60, 5 over 60, and what we get is a result 1.8 as relative ratio. Family history positive, family history negative, family depression with family history positivity is 1.8-fold more with the depressed patients. Positive family history is 1.8-fold more with the depressed patients in comparison to those who are not depressed. Relative risk has not changed in the second case. However, what is the p-value? P is 0.0002. Why? Because the sample size has increased. The possibility of finding a difference based on chance has decreased, and our confidence interval becomes 1.3 to 2.5. Let's look at the third case. The total number goes from 1,200 cases to 4,000. Why did not our p-value go down? Because our relative risk is down. 30% to 25%, 1.2 relative risk is lower. P-value is the same with the second study, but the relative risk is low. Let's look at the confidence interval. Let's see how narrow the confidence interval is. Why? Because the sample size has increased. We can change our p-value by changing the sample size. This is a difficulty. Why is this a difficulty? If you do not look at it from the clinical importance point of view, then you can see meaningful results with large numbers, and you can say, this is effective, and you can go behind that study. But clinical importance is very crucial. Let's look at the Beck depression points. There is no difference between 20 to 24. If the Beck depression score is between 20 and 24, it is not important in clinical terms. Let's say you had two groups and with an average of 25, then there was no difference between the groups, and I gave A antidepressant to one of the groups and B to the other. One of them went down from 25 to 23, then the other went down from 25 to 22.8. If you have more than 1,600 patients, then the result will be meaningful, significant. If you compare the drug A with the average of 23 to the drug of B with the average of 22, but then if you use about 60 patients, your results will be meaningful. And if you have 15 people, if the change is from 25 to 23 and 25 to 21, and the difference between the drugs A and B would have been significant only with 15 patients. But does it say anything to you? Does it mean anything to you in clinical terms? That's the important thing. In order to overcome difficulties caused by the sample size, NNT and NNH, number to treat, has been introduced. This is the strongest these concepts are widely used with randomized controlled studies. What does number to treat mean? One group, if we want to treat one more person with the agent in comparison to the other group, how many patients should I treat is the question we ask with number to treat. This is 15%. Let's say one group has a success rate of 15%, the other group has a success rate of 8.3. What is the difference? The difference is 6.7%. NNT equals 1 over 0.067. This equals to 15. That is, if I treat 15 patients with A drug and 15 patients with B drug, at the end of the 15th patient, I show that A is superior to B. This could be 130,000 or more patients. If the result is 15% to 80.3, if the difference is 15% to 8.3%, then this NNT will never change. What about meta-analysis? But I have 2 minutes and I will not have enough time. Meta-analysis is the method to be preferred with ambiguous, numerous studies with ambiguous results. Most importantly, due to small sample sizes, if we cannot decide about the results in small studies on their own, it gives a chance to analyze and understand the effects. We should be careful about its way of conduct. There is the concept of heterogeneity. You have to decide from the start. The studies including the meta-analysis, is it a problem about the sample or is it a problem caused by the study design itself? You should run heterogeneity tests in order to decide the model to be used in analyzing the studies within the meta-analysis, and then you perform sensitivity analysis to decide which factors have affected the results of the studies. You perform sensitivity analysis, you drop the bad studies out of the meta-analysis, and you look whether the results are meaningful. If there is unexplained heterogeneity, then there might be unknown biases and unknown factors at play, and therefore at meta-analysis complexity factors should be at least included in 75 of the patients. Bottleneck image is very important. It looks like this. Funnel plot is very important in comparing the two. The positive and negative results. You see the increase in sample size if there is no change. But here, there is something lacking here. There are no results in this area. There's an asymmetry. Based on this asymmetry, then you can say that these results have not been published. This funnel plot helps us to see the bias based on not publishing certain results. This is Leucht's antipsychotic combinations versus monotherapy in schizophrenia paper. You see no change yet change when the analysis is performed for all of these studies, and then you find that combined therapy is superior. Continuous variable, there is the Hedge score above 0 and below 0 show the difference of the two drugs. Sensitivity analysis, Leucht study again. Had it been double-blind and open design, how it would have changed? Chinese studies, non-Chinese studies, if we compare them, what is the situation? Trial duration less than 10 weeks and more than 10 weeks. When we compare the two, what is the situation? Based on these variables, do the results of the studies change? And you have to perform these calculations. As a result, randomized controlled clinical studies, when compared with meta-analysis, you might see mismatches. It's possible not to be able to reach unpublished data. There is the effect of heterogeneity between the studies. You should always watch out. We perform the meta-analysis and we see that there is a p-value results saying combined therapy is better than monotherapy. How many you have to ask yourself the question, how many studies should I have reached saying no difference between combined therapy to monotherapy to change the results of my meta-analysis? For example, the number might be 20, then you say, is it possible? Could there have been 20 unpublished data saying no superiority? You will decide it. But if the number had been 2, then it could have been possible. This is called publication bias. Yes, if you find 2 more studies saying no superiority, if the presence of 2 publications changes your results, then you say perhaps there is a publication bias. Conflicting results, small sample sizes, if this is the case in these studies in a certain field, meta-analysis should be performed. They can be informative, but they are like a blade with 2 sharp edges. If you can, join the results, but if you can't, compare the results.